Now for something completely different. My goal in this is to just toss out some ideas as I go through this presentation and get you thinking about maybe new ways you could do things that might be more powerful based on new ways that we're doing things as a society. So, and part of the reason I think I sometimes see things differently is because I began, like some of you, in this world as a parent. So let's see, which button do I push? Is it arrow? Yeah. Up? Down? There we go. Okay. My story here began in 1985 when my second daughter, Elizabeth, was born. She had a bilateral cleft palate and cleft lip and metatarsus adductus, so her feet turned in. But she was bright-eyed and alert, and so my focus was on cleft palate feeding and getting her nourishment and all the surgeries we were going to be in for in the coming days or years to learn about that. And we were absolutely thrilled because 6 weeks after she was born, my husband, who was in the Air Force, had orders to move to San Antonio, which is where the Air Force's big hospital is, where all the surgeons were. So this was like fortuitous. We were thrilled to be going to San Antonio. The day before we moved, the pediatrician called and said, I have some paperwork for you to pick up, and can you come in? So that's logical. He knew we were leaving. Went to his office to grab the paperwork. He said, have a seat. First clue. And he handed me a book, and he said, she has this. It's a really, really rare condition. There's only 60 other people in the world. She has a deletion from the bottom of one of her chromosome number 18. And one of the things the book said was they are probably the most severely afflicted among carriers of chromosome abnormalities. They maintain the frog-like position observed in infants and are reduced to an entirely vegetative, bedridden life. And there was this whole long list of medical problems, and I went through the list and I said, well, what's this, what's this, what's this? And he said, I don't know, I don't know, I don't know. Okay, so inhale, everybody. Hold your breath. You starting to feel a little shaky? Okay, this is where we are. Oh my God, what just happened? This is me, falling through the air. No parachute, no helping hand, nobody to ask for direction. My God, what is happening? And the ground is getting closer, faster and faster. And that's what it feels like as a parent. Okay, now you can breathe. Maybe, just for a little while. So that's what prompted me to found the Chromosome 18 Registry and Research Society 5 years later, after I sort of caught my breath and wasn't going to 3 doctor appointments a week anymore. And our mission is to help individuals with chromosome 18 abnormalities overcome the obstacles they face so they might lead healthy and productive lives. Seems like a lot compared to what we read about in the book. And we decided when we started that we would include people with all chromosome 18 abnormalities, because that way maybe altogether we could find 100 people. And so we better at least, be able to have a small group. So these kids can have a missing piece from the short arm or the long arm or an extra part of chromosome 18. And when nobody was doing any useful research other than just mapping genes, but not any research into the conditions that was going to provide any information to families, I decided to enroll in graduate school. So I got a Ph.D. in human genetics, and here's my graduation in '97. Here's my daughter in her vegetative state, along with my parents when I graduated. And the Chromosome 18 Registry, our lay advocacy group, accomplishes our mission through some broad things, which pretty much most all lay advocacy groups do. Service for our families in the way of conferences. We have an annual conference in the U.S. and usually have about 200, 250 people there. We have one every few years in Australia, and this last summer we had our first conference in Europe. And we have get-togethers the families throw for each other regionally around the country and around the world. And, of course, websites, listservs, all that good stuff. We're very interested in education, obviously, to our families, and we have podcasts and that kind of thing on our website. But we're also interested in educating policymakers, and we've testified a couple times. We go up to Capitol Hill once a year. Next week's our week. And talk to as many people as who will listen to us. And over the years, we have raised some money, and 5.1 million seems like a lot to me, but after the last talk, that's just peanuts. So it's not going to get us very far, and somehow we've got to figure out how to scale that up. Part of the reason we've been able to put so much money in research is we have really low overhead because this is our office. This is my house. I actually bought this house because there were about 1,000 square feet that was appropriate for office. And so we have about 4% of our income goes to the management and fundraising. We have 2 employees, so I have to get out of the garage by 7:15 every morning because Gloria is always there promptly at 7:15. And actually, of those 60 other families, we know of over 2,000 of them. So as you can see, those numbers were way off. And my graduate program, or research project, gradually evolved into the Chromosome 18 Clinical Research Center at the UT Health Science Center in San Antonio. And I got my degree in the Department of Cellular and Structural Biology, but all through that period, I kept telling the chairman of pediatrics, when I grow up, I want to be in pediatrics. And luckily, she listened. So at this point in time, we have 7 investigators with a % effort actually dedicated to the research program. This slide is a little old, I guess. I realized I failed to count our cardiologist, who I just snagged a month or 2 ago, and I've got another one, another clinician on the hook. I'm reeling them in. So we're maybe going to get to 14 volunteer faculty. We have 8 staff who support that between the lab and the dry lab, I guess, research assistants. We have over 400 participants, and they've all been genotyped within about 2,000 base pairs to know exactly what their region of the chromosome that's missing or duplicated is. And actually, as of this week, we have 32 publications and about 5 more in the pipeline. So we're writing away and pretty productive. And so through all this, we have 2 organizations. We have the Chromosome 18 Registry, which is the lay advocacy group, and then the Research Center. And one of the points I want to make is who does what. And because one person runs both, we have a pretty good relationship. I'm not that schizophrenic, but we've really drawn really concrete lines between what one group does and what the other group does. And I think there's something that maybe others will get something they can learn from this. The lay advocacy group does things for the families. We do conferences and newsletters and that sort of thing, member communication, fundraising, lobbying, or policymaker education, whatever you'd like to call it. And the parent organization sets the research priorities. Of course, they have the money. That's what you get to do when you have the money. But the research center really follows the lead of what the parents say is important. In fact, we just gave a seminar a couple weeks ago, and on tetrasomy 18p, we had just done an assessment of 43 individuals with that condition, which is about a factor of 10 more than ever been reported before. And we had a table where it says the incidence in the literature and then what we found, and constipation was like an 86% or some really high number, and it was 0 in the literature. And somebody asked me, well, how come that was not in the literature? And I said, well, because it wasn't important to the clinicians. It was really important to our parents. So at the research center, we really take our lead from what the parents tell us is important. On the research center side, we do anything that has to do with human participation, needs IRB approval, that sort of thing, even if it's just a mail-out survey. Of course, the bench research and the clinical research we do at the research center. Any expert collaborations. So if there was somebody, we needed some enzyme assay that needed to be done or mouse experiments, and we didn't do them at the research center would be the one to contract it, even if it was using registry money. So the research is really centered in one place. And I think one of the important things here is that the registry could easily send out a survey asking about medication use or something. But the registry doesn't do that, because that's getting into the research center's territory. The research center could easily look for big donors, but they don't do that, because that's the registry's territory. So we've really made divisions about who does what, and clear lines, good fences make good neighbors. And so clear delineation of who does what makes for a good and I hope long-lasting relationship. And that's where I think lots of people, groups get in trouble, is each group tries to get in the other's business. But even given all that history and my training in science, I never really lose that memory and that feeling of total panic. And that's where a lot of parents are. They're looking for a hand, and sometimes parents have observations about what they think they see. And as a parent, you often get questioned, well, you're emotionally invested in this. Like, that's a bad motive, and promotion and tenure is a good motive. So sometimes I don't always understand that, but maybe someone can explain it to me one day. And to parents who have observations and want to pursue studies and have things they've seen and they're trying to get somebody interested, sometimes it feels like what you're being told is, you're asking for a parachute, and I'm sorry, we decide who gets parachutes. And by the way, there has never been a randomized placebo-controlled crossover trial of the parachute, so we don't know it works. And what I'd like to have you start thinking about today is the whole mindset that really allowed the development of families to feel empowered and start lay advocacy groups has really been propelled to be in a much more powerful situation because of the internet. And as you've seen in the Middle East right now, the masses are getting more powerful, and institutions are sort of getting less powerful, less authoritarian. And so this can really work to our advantage if you understand what's happening and you use it to your advantage. And a really interesting book called What Would Google Do by Jeff Jarvis talks about these, and he calls them the Google rules. And I'm going to go through these and then apply them to rare disease research. So what are the Google rules? Well, first of all, they're increased connectivity. Customers have choices. Now, his book was about the business world, so all his examples are about business, but you can apply them to science and how we do science. So customers have choices. Locality is not important. You can't find the book you want at Barnes & Noble, you go to Amazon. So they don't have to have the book you want. The stores used to have a lock on what choices you had. They don't anymore. Locality is not important. Also, customers have an instant speakers forum. I mean, anything you want to do and you look it up on the internet, there's always a review of it, whether it's a book or a hotel chain or whatever it is. So there are instant speakers platforms, and institutions have to be responsive. And what that means is there's an instant crowd, and that crowd can either be your fans or your enemies. So you need to learn to be, as an institution, to be responsive to that. And the companies that cede control and are going to be the ones who win. So the ones who try to dictate, well, this is our product, you need to buy this, aren't going to do so well compared to the ones who say, oh, you're telling me you want that? Okay, we'll make that. So part of the Google rules are people can find each other because there's so much increased connectivity. And, you know, we used to say there's 6 degrees of separation. Well, I'll bet we find that there's even less of that now because people stay in touch so easily. Now, who hasn't found an old high school friend on the internet that you would have never found before Facebook? So we stay in touch with more people for a longer period of time. And kindred spirits, if you have a new love of whatever esoteric thing, you can find a whole group of people who love that too on the internet, and you can find it instantly. So people can find each other, and that means that a mass market for a mass drug, whatever, is much less important. Now we have a mass of niches. And so stores are really released from atoms because they don't have to have the physical widget on the shelf or whatever. They can just have a site where they show their widgets in every color. They don't have to stock them, and when you want them, they manufacture it and send it to you. So this is why you see more self-publishing, self-recording, and self-marketing of things, because somebody can write a book which might be on an esoteric subject or a rare, ultra-rare disease, and they can find an audience on the internet right away, where Walmart would never carry such a thing. The other part of this evolution is that markets are conversations. The old model was a company produced a product. Now, a smart company would try to guess what you might like so that you would buy it, but they would do that guessing. They would manufacture it, and they would put it out there for you to buy. They would figure out a marketing campaign that was going to catch your interest by making that product look very sexy, and only sexy people use it in their commercials. So, of course, you want to have that because you want to be one of them. So that was the old model. The professionals were the producers, and we, the amateurs, were the consumers. What's happening now, the new model, is many companies are letting consumers do some of the work. For example, Lego. If you make a great Lego model, you can put that, send that to Lego, and they can put it on their website, and they'll sell everybody little kits with just the right pieces to make your new model. So they've let their customers become the designers. So I guess if you're a designer or in marketing, you need to worry. But the rest of us are in good shape because we get to be creative. Also, product scarcity no longer dictates profits. So if you're a store and you have red widgets and black widgets, and the black ones sell out right away, no one really wanted red ones, well, you're going to have to buy them anyway because that's all there is. Well, that's the old model. Scarcity doesn't dictate anymore because people can find whatever they want over the internet and order it. So being the only store in town does not mean you're the only accessible outlet. So locality is no longer the key to success. And what's happening now is market premium comes from collaboration. And the ultimate example everybody knows about is Encyclopedia Britannica versus Wikipedia. Wikipedia grew unbelievably quickly on the theory that if enough people were the source of the information, that there would, of course, be mistakes, but they'd be corrected very quickly. And so the group thinking and the group activity would be what kept things accurate. And it made all that information available very, very quickly, much faster than anyone could do in a Britannica sort of model. So success is based on networks and platforms. So if you're selling widgets, what you want to be able to do is figure out some way that you have your customer make it to their advantage to tell their friends that they want a widget too, because widgets from the same company somehow interact with each other in a special way. So your customers want their friends to have it. And so success is based on sort of how you connect with your customers and how they connect with their friends. And so building networks in a virtual sense is much, much more important. And so ownership is no longer key. And this is an example that's, I think, very applicable to what we do. And this is a great example. So Goldcorp was a sort of medium, small gold mine in Canada. And they weren't doing so well, and they had a new CEO who was going to think differently. And in the mining business, your data, your geologic data is secret. Just like all your data in the lab, it's secret, it's proprietary. You do not let go of it. It's your claim to fame. It's what you're going to use to make your profit or your discovery or whatever. Well, this new CEO had a different idea. He put all their geologic data out on the internet and offered a challenge, a reward to the company who could figure out where the gold was best. And the winner of that was a small company in Perth, Australia, Fractal Concepts or something like that. And so what happened, because they were able to identify this new company who perfected their own data analysis software from real-life data from the gold company, the cost in 1996 before this challenge for gold was the company produced 53,000 ounces of gold at a cost of $360 for every one of those ounces. After this challenge and this new visualization of their data technology was implemented, the company was able to produce 504,000 ounces at a cost of only $59 an ounce. And down here's the price of gold. So you can see that became a very profitable company very quickly. And it was through releasing what they had to the public, what the industry had considered proprietary and secret information. So it's the crowdthink and the crowdsourcing model that can really help bring new ideas to a really old industry. So these fundamental changes really change the balance of power, but only sort of. I mean, if the end goal for us is to cure disease, we need to understand this change and make it work to our advantage. So what do the Google rules mean to the rare disease community? Well, first of all, rare is no longer second class. I hate to tell you, or I'm glad to tell you, we are in the leadership seat here, if we take it. And rare does not mean hard to find patients. You can find them. There may not be a lot of them, but you're going to be able to find them. And where in the past you may never have been able to find 6 or 8 patients to study. Now you can find a good number of them. And those patients aren't isolated either. They're likely going to know each other. So if you find one, they're probably going to know 10 others. That's the network process. And they also are not without a collective voice. One person living here, one person living there, they don't have a collective voice to go to the FDA or to Congress or whatever. Now with the internet, they all know each other, at least in the virtual world, and they can make their collective wishes known to whoever they decide to make them known to. So rare does equal, and has always equaled, I think, a very focused constituency. I mean, these are usually people who were told, well, I'm sorry, it's really rare, and they get a blank stare from every clinician they go see. So they become educated on their own, in part from learning about their own disease process and their own life story, but in part from meeting other people and reading what they can. And so usually the rare disease research community is really fortunate because they have a highly focused, really well-informed set of participants that lots of other disease groups that are common don't have. So this is sort of my opinion of where we are in broadest terms at the moment. You know, phenotype rules, and I think we've been seeing examples of that today. You know, genotyping, that was so last century. Now it's all about phenotyping. And where this is going to be so important, and again, people have touched on these things today, you know, when we were genotyping and doing linkage, you either had the disease or you didn't. Well, it's really not that simple, and we all know that. And the richness of what we're going to learn from rare diseases is going to come from understanding differences in the age of onset, differences of severity, levels of whatever biomarkers you want to talk about, all the associated findings that go along with it. And of course, the natural history or the unnatural history from when people are being treated. So the rare disease community, because patients are connected, because patients are well informed, they're connected with each other, and they're probably connected with you as researchers, are really going to be very helpful in figuring out all these phenotypes. Because I can tell you from experience, because we think we have this fabulous phenotypic database with everybody's medical record who has a chromosome 18 abnormality. As soon as some gene is discovered and causes a problem through haploinsufficiency, and I say to Mimi, okay, pull up everybody that's got XYZ phenotype and let's compare it to the genotype. I have, 50 people who have the genotype and 10 of them who I have that phenotypic information on. I have to go back to the families and ask, get more medical records, or ask them to have a certain test, or bring them in and have it. So no matter what you do, no matter how wonderful you think your phenotype database is, it's never going to be sufficient. So what you have to do is you have to have this ongoing longitudinal lifetime relationship with the families. And this is where the rare disease community has been ahead of the game all along, because this has always been a part of what we do. So some ideas I'd like to throw out there and have you think about is what would the Google rules mean for the rare disease community? And how do you build those kind of relationships that are going to enlist the goodwill of the masses as they see other things happening in the world? One thing you could do is give participants access to their own data. Our healthcare system is so completely fractured, as you all know, that, you know, Dr. 1 has this information, Dr. 2 has this. I mean, your information is everywhere. And if you have a complex rare disease, you're the one having to manage it. But what if the research center managed all that and they let you get into that data and you could see it all in one place? They would have, that research center would have your undying support because you just made life easier. Maybe participants could even update their own data. They start on a new medication, maybe it seems completely unrelated to their rare disease, but wouldn't you want to know it? They should be able to tell you about it. So let participants update their data. And really, the more extreme idea here is let participants query the data set. Completely anonymized. But what if a patient started taking a medication for something they thought was unrelated to their rare disease, and they had a really bizarre side effect? What if they queried the database and said, wait a minute, 6 other patients out of this group of 50 took this same medicine and had this same side effect? Would you ever have thought to look for that? No way. But the families might, because they've got the time to think about it at 2 a.m., and they may give you some really good leads. So just like the Goldcorp thing, with lots of people looking at the data, you're going to find things you never dreamt to think about before. Also, participants could have an interactive platform as part of that. Somebody could ask the question on the database, I just took this, I had this reaction, did anybody else have it? So, and the most simplest way to do something like this is, you know, Facebook has private and secret pages, meaning private that you can't get on it unless you're asked, and secret that it can't, if someone does a search, it doesn't appear to exist. So it can happen, and people can exchange information that way. So what does this mean to researchers? Well, sort of, you cede control. So, but you extend your eyes and your ears. You have all those people out there who might see something in the data you didn't see, who might see something you never even thought about before. And they're going to tell you about it because you have enabled them to start thinking about this. And I get parents all the time who send me papers they've seen on PubMed. And sometimes, of course, I saw it, I wrote it, or, you know, no, I don't even see the relevance, but they did, so I look at it and I think about it, and maybe that gives me a new way to think about something I hadn't thought about before. So extending your eyes and ears is very helpful. There's just so much literature out there that it's so hard to keep up with. And increased understanding on the part of the patients, I hate to call them patients, but you know what I mean, really means increased involvement. The more the affected families know what you're doing, and the more they feel involved in what you're doing, the more they're going to be spokesmen for what you're doing. They're going to defend what you're doing, how important it is, whether it's to members of Congress or their friend next door. They will extend the message and the information. So increased understanding means increased involvement. Oh yeah, and they might do more fundraisers too. I almost forgot this. Most importantly, and I would also say for researchers, don't be afraid to tell the families, this is what I need from you, because sometimes they don't know what you need. You need to tell them. So what can this mean for the advocates? Well, the advocates can help make sure research gets focused on the things that matter to families. Some things are really a big deal to your quality of life, and a researcher may not have appreciated that yet. Just like constipation was a really big deal for all our tetrasomy 18p families. And and the advocates, of course, can get a better understanding of the condition, and hopefully they can accelerate the race for the cure. But I'd say the advocates, the question needs to go both ways. The researchers need to ask the advocates, what do you need from me? But the advocates need to ask the researchers, what do you need from me? So it needs to go both ways, and there needs to be a conversation. So I'm going to skip that. And the real message is, this is really where we are. We're all fallen, and the ground is coming up, and we better hang on to each other, because we're all in this together. But we have a very long ways to go. These were 3 of the 5 comments in a summary statement that I got last June, that the weaknesses of the study was it only involved chromosome 18q disorders, and the current application is a rare disorder, and it's not a randomized trial. So if I only knew who this was, I want to volunteer them for the placebo arm of the parachute trial. And here's my daughter, Elizabeth, in her high school graduation picture compared to the icky pictures I was shown when she was diagnosed at 6 weeks of age. And I'd like to recommend some reading to have you think maybe lots of different ways about how the internet and the Google way of doing things in this new world can actually help accelerate the race to the cure. That's really what we're all here about. Thank you for your attention. Yes, sir.
I just wanted to comment about the internet capability. This is something that we've done over the last decade. In fact, I took Ingrid Cactus's advice and made a therapy available to everybody, and then took the data that was coming back in to find out exactly what the effects were and exactly what conditions were being addressed. But, you know, I sat in building number 1 at NIH, the Office of the Director, in 2007. I was told to my face I was deluded, I was not a scientist, I was an internet quack. And then I sat in, well, I didn't actually sit in, but I've spoken to OOPD on the phone and been told exactly the same thing by OOPD. And somebody from OOPD wrote a blog specifically criticizing our science using confidential information that we've provided to OOPD. I mean, you have no idea how much prejudice there is.
I do.
OOPD and NIH against the internet.
Yeah.
So it's very important for people to understand that before they get too heavily involved. Incidentally, we're well published. We just published in the next publishing group journal as well.
Well, I would say to you that 3 weeks ago, that's what the ruler of Egypt said too. Things change. And, you know, and when you think about what's happening, sort of with the internet revolution, I mean, the first thing that happened was companies changed. I mean, they had to be. They live and die by what the consumers think. Now we have the other end of the spectrum where entire countries are changing. What's in the middle is bureaucracies. And the same thing's going to happen to the bureaucracies. And there's going to be, I fear, big changes if some of these changes aren't embraced by the bureaucracies.
And embraced at internet speed, which is the other
Oh, yeah, absolutely.
Because, you know, I sometimes wonder whether we're going to see another new branch of medicine come out of this type of technology, just the same way as alternative medicine sprung up in the 90s. And I guess Steve Rock can tell us more about that.
Let's put Steve on the hot seat. Yes, ma'am.
What the internet has done in my life for people with rare diseases has been they took MHE from nowhere and was able to contact Yuya Yamaguchi. The vast majority of the researchers that are now today, and I had the time to sit and speak to every single MHE concerns. And because of the internet, you always get a small organization for a meeting. There's conference calls. We established the United States Bone and Joint Decade. Rare Bone Disease Patient Network, and that's the information. Now, there are organizations that are banded together, so or sharing resources that another organization, when they don't have, we have, and working together.
That's where I think the rare disease community actually was already poised to really embrace this because of the history of close collaboration with lay advocacy groups. Actually, a lot, because Steve always said that's just how it is. I mean, how else would you do it? And I think that sort of mindset that he had years ago, 20 years ago, has permeated the whole community. And so I think that's why we're light years ahead. And we're a great example, and we shouldn't hesitate to point that out. I mean, in the CTSAs, you know, everybody's got to do community engagement. Well, and translational research, and I'm saying, well, we've been doing that for 20 years. Why are you looking out there for examples? And when it's already been right here, just, you know, emulate what we've been doing and been working at for many years. So I think we're, as a community, not tooting our horn the way we should. So, yes, sir.
I'm a clinician, and I see two groups of you know, patients, parents, and advocates. I work at a major medical center in Los Angeles, and about 2/3 of our patients were not connected with the internet, and we would give them information on advocacy groups, and because of language barriers or whatever, they wouldn't come. And so it seems like there were the you know, English-speaking educated patients who were connected, who did have the choices, and there was a major group who didn't. And so my question is, how do you get those people in? Because that would help.
You know, I ask myself this question almost every day. The parent advocacy groups are a white middle class thing. That's how people in the middle class in this country think. They say, I have this problem, oh, well, I'm going to see how I can solve it. And the poor and disenfranchised tend to not think about that. They expect to often, I know I'm generalizing, and it's also cultural. You know, it's a Northern European way of seeing life. I'm in South Texas, and so it is not the Hispanic way to do things at all. And so I guess the way I sort of have approached this is maybe if it's our responsibility as part of being in the lay advocacy movement to make sure that the way other groups get information, that those places have information. So they would go to their physician or their pharmacist. Well, it's up to us to make sure their physicians and pharmacists have that. So they may never belong to our organization. They may use different routes. And so if there's information, we got to make sure it gets out there. So I don't know if that's a bad excuse. I don't, you know, I ask myself that all the time. Should we be meeting in the Baptist church in the inner city? I don't know. So, but it's a really valid point, something we can't ever lose sight of.